Okay, good afternoon. I'm Dr. Ginny D'Olympia, the Director of our Military and Veteran Programs at William James College. Welcome to the fourth presentation in our 2023 Military and Veterans Mental Health Series, where we will be discussing the needs of the aging veteran population. Over 1/3 of our veterans are over 70 years old, and they represent the largest population of U.S. veterans with service between anywhere between peacetime and in all of our wars since World War II. Our guest speakers today are Dr. Dipali Patel and Dr. Morgan Longstreth, both clinical psychologists at the Bedford VA Medical Center. Dr. Patel specializes in providing psychotherapy for homeless veterans with mental health, substance use, dual diagnoses concerns, while also conducting research and supervising doctoral trainees in evidence-based practices. Dr. Patel is also a graduate of our clinical psychology program at William James College and has been involved in our military and veteran programs for many years. Dr. Longstreth provides geriatric-oriented care to older adult veterans in the mental health clinic with a focus on evidence-based psychotherapy for conditions such as PTSD, depression, and complicated grief. In this discussion, they'll explore the mental health needs of aging veterans and how to address them through evidence-based practices. Dr. Longstreth is a graduate of the University of Wyoming Clinical Psychology Program. Thank you for joining us. Our program is provided through a partnership between the Executive Office of Veteran Services in Massachusetts and William James College. We are very encouraged by your interest in supporting the mental health needs of military veterans and their families. Please feel free to introduce yourselves, your connection to veterans, and your location in the chat. Throughout the program, we will be addressing any questions in the chat, and they will also be addressed further by the speakers at the end. Thanks for joining us.
Thank you, Jenny, for that lovely introduction. And good afternoon, everybody. So glad that you can join us this afternoon. So today I'm here with Dr. Morgan Longstreth, and we're going to be talking a little bit about the intersection of aging and veteran mental health. We're really only going to get to sort of like the surface level stuff. There's so much work and so much to be said about the needs for this population, but we'll do our best. So we're going to be sort of going over a couple of things. We're going to be talking about, of course, the ways in which aging sort of intersects with mental health for veterans and also just the general needs for this population. And we're also going to be talking a little bit about sort of treatment adjustments or modifications to sort of meet the needs and also benefits and supports available, particularly through the VA, but also in the community a little bit related to access to care and also just supports that sort of provide treatment for various needs that this population will be facing and are facing currently. And we did title this presentation Integrity versus Despair, sort of talking a little bit about Erickson's, right, the final stage of sort of his model, thinking about sort of the stage at which people, right, are reflecting on life that they've lived and come away with either a sense of fulfillment, right, or satisfaction, or maybe a sense of sort of regret and bitterness, and sort of how this can color people's experiences with mental health and life more generally speaking in older age. So just a disclosure statement real briefly. Neither myself nor Dr. Longstreth have any conflicts of interest to report regarding this presentation.
And you know what? Bear with me for just a moment. I opened up the PDF version of this and we're missing our first fun slide. So give me just a moment to pop that slide up.
Perfect. Thanks, Morgan. And while we get to that slide, I think we were hoping, some of you have already started introducing yourself, which is wonderful. It's helpful for us to know sort of where folks are coming from, sort of what populations you work with. So as Morgan's pulling that up, we'd love to sort of know maybe primary practice settings, so where you're practicing or what your role sort of is, and also what is the typical population that you serve in terms of patients, just to give us a sense of if we're talking to folks who are more familiar with veterans and the veteran culture, or folks who work with older folks already. So if you could just pop that into the chat for us so we can get an idea, that would be wonderful. Seems like we have somebody in private practice. Yeah, somebody who works with sort of veterans in SUD treatment and also has a personal connection, which is great. private practice, and we have a contractor who does comp and pen exams. Wonderful. Yeah, we have some sort of, familiarity with the culture and the population, which is great.
Dipali, can you see my slide now?
I can, thank
Okay,
you.
good. Just making sure. Sorry
Yeah.
about that. We'll get all the snafus out of the way at the beginning, right? Get them all just taken care of right now.
Yeah, perfect. All right. Everybody a second more. Oh, great. We have somebody here from New England Center and Home for Veterans, somebody that I work really closely with over here at the domicile area at Bedford. Just great to see a familiar name. So yeah, we have some folks who are definitely familiar with it. And you can feel free to keep adding sort of your introduction, where you're from and your connections. That'd be great. But we're also going to do something a little bit fun that we like to do to sort of get a sense of what folks are thinking of our initial reactions, almost like a free association game, if you will, a little bit. And maybe you've done this in other virtual spaces, but we're hoping to do something of what we call a chat waterfall. So we're going to pose a question to you all, and we're going to have you type into the chat your response, but we don't want you to click enter just quite yet. We want that to sort of come at the same time. So we'll give you a minute or so to answer this question, which is really, what comes to mind when you hear older adult veteran? And just feel free to write in any initial reactions or thoughts that you have. And then when I say go, you can go ahead and enter in those responses. So we'll give you a minute to do that. All right, and feel free to go ahead and post them. Yeah, grief and loss, World War II, male, grumpy, grouchy.
Grumpy, that's sticking out to me right away.
Yeah, Morgan works very closely with this population, so I'm sure some of this is like very much hitting home for her. Hard for them to break the no talk rule regarding experiences or need for help. Yeah, the stigma piece, absolutely. Underserved, unaware of eligibility. Yeah, definitely a barrier to access to care. Frail, needs support, lonely. Yeah, wise. I love that. That's wonderful. People who fought in World War II in Korea, but my peers who may have fought in Vietnam are now older people too, which speaks to I think a really important part of this. And Morgan will get into demographics in just a second, but right, this aging veteran population that we're seeing in today's world. Complicated medical and mental health history. Yeah, that's a perfect way to encapsulate sort of the complexity of this population and their needs as well. I used to think old white man, Vietnam vet, because I grew up in the 80s rural America, but in the past worked with women and other individuals who expanded my idea of who is a vet. They aren't necessarily someone you can identify by the way they look. Yeah, that's beautiful. I think I've seen an image going around the VA where it sort of shows like a sort of mural of veterans. And yeah, there's really I think people can have ideas, but I think that, again, the diversity that we're seeing in sort of the veteran population, which we'll talk about intersectionality of identity towards the end of our presentation. Misunderstood. Yeah, these are all, I think, these really hit home to me. I think before I started doing work in the VA as a trainee, I had sort of similar thoughts and sort of carried those with me. Morgan, I'm curious to know what sort of sticks out to you.
Yeah, well, and I think what I'm seeing in the chat is what was reflected when I did a basic Google image search for this presentation. I felt like our presentation was a little text heavy. And so I was like, oh, maybe I'll add some images. And it was exactly what y'all put in the chat, right? Grumpy, tired, misunderstood, Vietnam or older veteran. And frankly, I found that quite depressing. So I decided not to include a lot of those images, right? Because I think one of my goals for this talk today as well is to share how, while that might be an accurate representation, right, there are definitely some other folks involved in this as well. Religious despair as well. Yeah, I work very closely with chaplaincy here at the Bedford VA. And this is something that does come up quite often. And we'll touch on this, like Dipali said, just briefly when we discuss intersectionality. But that is also a really good point and something that I will also explore a little when we talk about grief. So if we're okay and ready to jump right in, I'll start us off with talking just a little bit about the demographics of older adult veterans. And so first and foremost, the kind of standardized definition of an older adult is 65 years and older. But that varies also state by state of what is an older adult or vulnerable adult. And so, for example, in the state of Massachusetts, it's 60, which is quite depressing for a lot of folks, I think, and not really exactly when we think of vulnerable, maybe what comes to mind. And that is also maybe my own bias working with older adults all day long. Old to me means something quite different. So, but we'll go with the kind of standardized accepted definition of 65 and older. So looking at the median age of male veterans, in 2017, the median age was 65 years old, as compared to the median age of male civilians, which was 42 years old. So quite a big difference here. So we're seeing that our veteran population is aging significantly. And though veteran populations are expected to decrease generally about 1.8% per year over the next 30 years for a total decrease of about 40%, the number of veterans aged 65 years and older is expected to remain relatively stable. And so in 2020, veterans 65 years and older made up about 46% of veterans served by the VA. And as we look forward, we see that number goes a little higher as the Vietnam age group kind of continues to age, and then really only drops down in the 40s. And so we see that even though veterans are declining in general, right, in numbers, they're not necessarily getting a whole lot younger. So clearly there's a need here to consider the unique needs of aging veterans, a group that in my opinion doesn't get nearly enough attention for the size of this population. I specialized in aging and geriatrics when I was in grad school, and there were quite a few of us who did as well. We had no classes on aging, nothing specialized during our training, and I really had to find and seek that out on my own. And I think, as I'm sure many of you realized when you signed up to come today, that that's probably the case for y'all as well. So moving forward and taking a look at what is a part of this developmental stage, there's quite a lot of benefits as well as quite a lot of challenges. So benefits are probably things that many of us are looking forward to: fulfillment of life goals, satisfaction, wisdom, hopefully some financial security, envisioning maybe some socio-emotional supports, really looking forward to retirement. I know when my veterans come in and they say, oh, I retired last year, I always joke, oh man, I can't wait to be where you are. And they're like, didn't you just get started? Still looking forward to it. And kind of, I think we envision a sense of self-actualization for older adults where they have space and time to explore themselves, their identities, their goals. And at the same time, this coexists with multiple losses, whether it be new medical diagnoses, physical and mental health challenges, loss of social supports, loss of emotional supports. Many folks are facing quite a bit of financial insecurity, especially in the current financial climate, or a continuity of financial struggles seen in younger life, hard to break out of, disenfranchisement and disempowerment, which I think is surprising to a lot in a society that claims to revere wisdom, aging, elders in general, and a difficulty accessing needed supports. And so while those supports may be available in their communities, it might be hard for older folks to know where to find those. So looking at the diagnostic profile of what we'll get into a bit today, aging veterans present with a greater clinical complexity than their civilian older adult peers, as well as than younger veterans and non-veteran cohorts. So we're seeing significant multimorbidity in our older adult veterans. Much of this is due to toxic exposures while in the military, as well as chronic mental and physical health problems that have really weighed a toll on these folks throughout their lifespan. And we'll be talking in detail about adjustment disorders, depression, suicidality, grief, cognitive change, and we'll explore some of legacy and life review, some anxiety, PTSD, substance use disorders, SMI. So we'll take a look at these further. Starting off with adjustment disorders. So if that hasn't hit home already, there's quite a lot to adjust to, right? Lots of changes. So physical health, chronic or terminal diagnoses, changes in functional ability, chronic pain, adjusting to an increase in reliance on others for support, whatever that may be, retirement, changes in housing circumstances, loss of identified supports. So that's just to name a few things. I did a chart review of just kind of my adjustment disorder folks and what they're going through. And this is just a bit of it, right? So I think the biggest part and the biggest challenge in adjusting for older folks is bridging this gap between their expectations for aging and the reality that they're experiencing. And so like we discussed before, many of us are looking forward to retirement, and getting older is a time when we have more control or autonomy over our lives. Unfortunately, this is a privilege and not often the case for many older folks. And therefore, it can be really challenging for them to rectify the differences between expectations and reality. Maybe some folks really look forward to retiring and spending a great deal of time with their grandchildren. And around the time that they retire, their grandchildren go off to college and kind of never to be heard from again, right? Or, they have these idealized images of what their future will look like when they have time and control over their time. And unfortunately, it often does not look that way. And without the structure of employment for many folks report difficulty finding that get up and go to engage in that long list of activities they've been looking forward to their entire lives, not to mention the pandemic, right? And so especially for folks who are living in this post-pandemic world and maybe retired or made the choice to retire around that time, can be hard to engage in those valued activities like they planned. Relatedly, depression. So depression in older folks, you may know or may be familiar with, looks a bit different from depression in younger folks. So we're not looking for a sobbing depression marked by a lot of crying or kind of positive depressive symptoms, right? Instead, we're seeing a lot of disengagement, veterans having trouble describing what they're feeling, aside from saying, I don't know, I just really don't feel like myself, right? This is not me. I've never felt like this before. I feel distant. I feel disconnected. So pointing to social engagement, as well as an increased sense of helpless or hopelessness. And so as we'll talk about a bit throughout this presentation, a lot of veterans, due to quite a lot of encouragement post-separation from service, have engaged in pretty successful avoidance, right? Avoidance of emotions, avoidance of trauma. Just hop out of the service, get a job, get married, and get on with your life, right? Move on, which was the messages that many were given by the service and by society. And so due to that very successful avoidance for a very long time, they might also be quite emotionally numb, quite unfamiliar with their own internal experience, and have trouble knowing where to go next and knowing what they are experiencing. And especially in older adults, depression is often or underdiagnosed due to a manifestation through physical symptoms that are traditionally associated with aging, like increased pain, poor sleep, appetite changes and poor intake, increased vulnerability to illness. And each of these things also have the potential to result in a high likelihood for poor outcomes, right? If we think of someone who is experiencing poor sleep or is not eating regularly, right? They may be experiencing adult failure to thrive, may lose significant weight, have a significant car accident, or trouble recovering after a fall, right? And so high likelihood of poor outcomes and also worsened cognitive function. And so I think this is one of the biggest pieces that is important to consider, is that depression in older adults often mimics cognitive impairment and what we would call a pseudo dementia, that the symptoms, once identified and treated, can largely resolve, but not always, right? So research does suggest that untreated pseudo dementias result in an increased risk of irreversible dementia. But there is a high likelihood for symptom improvement and recovery if addressed adequately, and if people are trained in knowing what to look for and how to tell these things apart. So wanting to be mindful that A can look like B and B can look like C, and it might take a little extra time and effort to be able to pull these things apart. And related to depression, just touching on suicidality. And so for some context, I also work in hospice and palliative care. And so I think I'm especially sensitive to teasing a lot of this apart within the aging process as well. So as we know, there are a high number of risk factors amongst older adults for suicidality. Older white men are the most likely to complete death by suicide. There's a 3 times higher likelihood of using a firearm in a successful suicide attempt in older adult veterans than younger adult veterans, so using more intentional and violent forms of suicide attempts. Risk factors that are common, of course, are chronic pain, chronic mental health and physical health concerns, extensive exposure to trauma and death. And something that I think is really interesting, a report from the VA on suicide showed that 43% of suicides amongst older adult veterans were associated with transitioning into or out of residential long-term care. And so this is something many folks are facing, right? But is obviously a huge, huge adjustment and a huge challenge to face. And also suicide risk is significantly elevated during the 6 months following discharge from a VA community living center or nursing home. So if you're working with folks that are being discharged from a CLC or acute residential care at the VA, really being aware of this, right? The important thing is also to evaluate the difference in older adult veterans between increased thoughts of death due to friends passing, new diagnoses, and consideration of approaching end of life from intent to harm or kill oneself. And so I think when you're, and maybe this is something that I may be a little more weirdly kind of comfortable with, right? But if we consider what these folks are going through, say they're approaching long-term care, they're adjusting to, say, a cancer diagnosis, isn't it normal to kind of have some of this on your mind, right? But I think us as providers here, well, I've been thinking about death and the sirens go off, right? I think that's a kind of a trigger for us as providers. And so a lot of times, especially in hospice, we hear people saying, well, I want to be done with this treatment. I just want to be done with this, right? So what do they mean by this? Is it the chronic pain? Is it the nurses coming in constantly with medications to treat their symptoms? Is it stress from tons of medical appointments? Or is this life itself? So pulling that apart a little bit, wish for hastened death is not always suicidal ideation. But on the other hand, looking at medical noncompliance within a suicidality framework, taking into context the way they're engaging with medical care and healthcare that's recommended to them, yeah, they might be burnout on constantly pursuing new treatment options, meeting with doctors, coming into the VA for appointments, and decide to suddenly stop, right? So if a veteran suddenly stopped taking all of their medications and actually seemed to be aware of the risks, how might you think about this? I think a lot of us, it would be quite challenging to know what to do in this situation, right? And how to respond. I think we might not also notice right away, right? So this is something that can be done quite under our radar. But I think the important thing here is teasing each of these pieces apart, and I'll probably say that 100 more times because it really is, there's so many different facets of it to look at, and really taking the time to ask the questions of what is going on here and being honest with the veterans about that as well. I've had far more luck when I was upfront and asked, right, than when I assumed. So related to depression and suicidality is also grief and bereavement. And so it can be facing grief related to the loss of another or loss in functioning of the self. Maybe it's anticipatory grief in the loss of another or anticipating the loss of a self, right? I see this quite often in hospice where people start to disengage or engage more in life review as they're facing an imminent death. Regardless of what they're grieving, the grief process has a significant impact on the mind and the body that requires our attention. Social isolation may be especially relevant here, as people may feel that no one understands them in their grief. Even other family members, spouses, children, friends who are experiencing this loss alongside them. They may have lost different people, right? Different versions of that person or thing. And they may attribute different coping styles to this feeling of being alone, right? Some reach out for support and some pull in. And so it is easy for them to feel quite alone. And in terms of this disenfranchised grief, I think this is a really interesting piece. So just to define it, disenfranchised grief occurs when someone is grieving something that society or other people do not understand or do not accept. So for example, the loss of a hidden or stigmatized relationship or identity, a pet, loss of time, a loss of phase of life, space, home, loss of a pregnancy that remains unresolved, an abortion in the past, right? And I've seen this coming up quite a lot as abortion and birth control is in the news often, a lot more frequently. And people say, wow, I've never really considered that. Maybe I'd never really processed through that when I was younger. This can also present in the loss of opportunity to explore identities and exploring maybe different phases earlier in life due to following roles or direction or kind of stereotyped male gender roles. I see this a lot in veterans. And maybe their spouse passes and they have an opportunity to do this and they grieve for the time that they didn't do this for the rest of their life. And an important note here is also on complicated grief or prolonged grief disorder. So this occurs when the kind of normative symptoms of grief are complicated by what are called derailers, resulting in prolonged and often worsened symptoms of grief, defined by a persistent and pervasive yearning, longing, or preoccupying thoughts and memories of the one who is lost, and resulting in impairment in functioning. And those derailers, as we see here, so risk factors for grief developing from typical grief to prolonged grief disorder, circumstances of the loss, the bereaved person's characteristics and own mental health, the relationship with who or what was lost, and again, past mental health concerns. So those are all risk factors putting one at risk of prolonged grief disorder. And at the same time, some protective factors are an ability to healthy integrate grief, strong social supports, spiritual well-being, and psychological flexibility, which many of our veterans are lacking in each and every one of these protective factors, right? Putting them at very high risk of developing prolonged grief disorder and more impairment from a loss, which is, I would say prolonged grief disorder is a somewhat new diagnosis, but has been kind of increasing in prevalence post-COVID as well, as people were not able to spend time with loved ones at the time of the loss and different facets like that. So related to loss, I do quite a lot of work with connecting to values and legacy. And this is kind of some of the most fun work that you can do with someone. So if someone is going through a grief process or has recently gone through a recent significant change, they may find themselves disconnected from a sense of purpose or meaning in the present, kind of fits into an adjustment disorder, can be related to the disillusionment of aging. Especially, I know I've said this a few times now, but especially seeing this in a post-pandemic world where people felt really disconnected from face-to-face values and struggled to connect with values through other venues. So kind of conceptualizing this sense of disconnection and validating that can be really valuable for veterans. They may also anticipate some unfinished business related to military service, trauma prior to the military, things that they never really taken the opportunity to explore. And so it's important to facilitate and allow them to connect with what is meaningful, to assess values. The unfinished business might be very existential, it might be tangible, so can be really fun to look at deeper. And if they're facing a disconnect related to, say, impairment in physical functioning or mental health functioning, can be nice to reconceptualize this from ways of doing into ways of being. And so how do you find meaning and purpose in this state of being that you're currently in or feel kind of imprisoned by? And the best part is empowering choice and autonomy for a veteran who feels and has felt likely disempowered throughout their lives, right? So giving them the opportunities to engage in treatment planning and making this really what they want to be. Obviously, we're going to do that anyways, right? But really making them feel like it is their choice can be really enlivening for a lot of folks. And now on to anxiety. Many focuses, just like anxiety in younger folks, can evolve over the lifespan. Something that I'm, noticing quite a lot is that certain illnesses associated with military exposures, like Agent Orange, like COPD or CHF or other pulmonary illnesses, may trigger or exacerbate symptoms of anxiety and make it challenging for veterans to engage in traditional anxiety treatments like mindfulness or breathing-oriented relaxation exercises. And so we'll talk a bit more about adapting treatments for older adult populations at the end of the presentation, but just something to be mindful of is that certain physical impairment or physical symptoms in general might, trigger symptoms of anxiety that make it hard to tackle in ways that we're usually prescribing. And as folks notice cognitive impairment or cognitive changes, they might be especially oriented towards health anxiety, anxiety about the future, ambiguity of what is to come for them. And on this latter point, as we age and our lives feel increasingly focused on our health and bodies and bodily well-being, we see a lot of kind of skin picking, body-related phobias, body-related OCD, bodily-oriented anxieties still prevalent as that focus really turns inward instead of out into the world, even though we might often associate these with younger cohorts. And cognitive impairment. So a lot of the research will tell you this is most prevalent amongst World War II to post-Korean War era veterans, which is true because they're the oldest old now, right? But we see this also increasing in prevalence in VA clinics as the Vietnam population ages. And so, for example, veterans with Agent Orange exposure are more than 2 times more likely to be diagnosed with a dementia than those who were not exposed to Agent Orange. It may also be related to service-related factors like TBI, which unfortunately is not very well evaluated in military service eras prior to OIF veterans. And chronic mental health concerns like PTSD, they weigh heavily on the mind, right? And on the brain and take a lot of resources away. And so can really contribute to declines in cognitive functioning. And at the same time, some of this might also be age normative, right? And so doing a little extra legwork, a little extra assessment to see where this feels like it's coming from. For those unfamiliar of what to look for, we're really looking for significant memory impairment, an inability to recall family members' names, familiar phone numbers, recent memories, and changes in short-term memory. We're a little less concerned about long-term memory change and loss. Recalling things from 30 to 40 years ago is not uncommon, even with significant cognitive impairment, and a difficulty in managing the activities of daily living that they previously felt competent and able to take care of. Maybe also some personality changes, increases in anxiety and anger, increase in symptoms of depression, social disengagement. It's important for me, especially to note that, I went too far, sorry. Important for me to also note that just because folks are suffering from cognitive impairment does not mean they're not able to benefit from psychotherapy, and really appreciate the opportunity to explore what they're experiencing, even if it's hard for them to verbalize what that may be, to learn more about dementia and what the future might look like for them, and to kind of have a venue to explore this, especially in a group setting. So a lot of guys like to explore this with their peers as well. So I'll hop off the mic and invite Dipali in.
Perfect. Thank you, Morgan. So I'm going to talk a little bit about PTSD and also relatedly moral injury, talk a little bit about substance use disorders, and then serious mental illness or SMI. And then we'll move into sort of the part of our presentation that talks about psychotherapy considerations, treatment engagement, and sort of benefits and supports and things like that. So I'm just being mindful of time. So I'll move through this. And then if there are questions at the end, again, we're happy to answer them. And we also have our emails in case you need to get a hold of us after. So PTSD is something that we see quite often, of course, here at the VA and in general, right, with this population. And I think it's important to sort of frame this in the context of oftentimes folks in the older veteran population, right, they've lived through that shift sort of in our field and discipline from shell shock to PTSD. So they've really seen sort of the formation of this diagnosis more formally when it was introduced in DSM-3 after advocacy, right, from Vietnam era veterans. So it's important to sort of think about like their familiarity with it, sort of how they conceptualize it because of how society conceptualized it at that point. And it's also important to think about sort of how this might impact, right, their ability to talk about it, and which we'll talk about in fear about disclosure. So right, oftentimes it can be previously unexplored in therapy for this reason. But one thing that we do see as a sort of difference, right, it's marked by more notable avoidance and numbing than we see in maybe our younger cohorts of veterans. There's also this shift culturally and societally around acceptance of being in therapy, right, or mental health, and that stigma and sort of how it's shifted. So we also think about just that ability to sort of engage in this sort of work, or even think that it's something that they should be bringing into therapy to talk about. Right, and then we see the related fear about disclosure, right? Fear that discussing or exploring it will actually make it worse, right? Fear of being judged by their therapist, maybe by themselves or other people in their family or close circle for disclosing their trauma. Particularly, this reminds me about, right, that culture of silence after Vietnam era war veterans returned, and sort of just not talking about their experiences out of fear of judgment. Right, and we also know that the evolution of symptoms of PTSD, right, they evolve, and so they might interact with life circumstances as they occur throughout life, but also, right, that they might have been able to previously actually be successful in avoiding their symptoms, right? We think about sort of tasks that are in our developmental stages when we're in middle adulthood, right? Going to work, having children, taking care of them. There are things in life that most folks are attending to that can keep them busy, that can keep them distracted from actually, right, attending to trauma that we have experienced. And so oftentimes, right, these symptoms are reemerging, or they're becoming way more obvious to folks later on in life. And also, right, there's also the piece around that they might evolve with life stress and also just current events, sociocultural sort of environmental stressors that folks are going through. I think both Morgan and I have had experiences working with veterans where we've seen recent current events, whether that be, the Black Lives Matter movement, coverage of the conflict in Ukraine, the COVID pandemic, that can really sort of be re-traumatizing for veterans, older veterans, and sort of their experiences and their index traumas that they've experienced. And so I worked with some veterans last year, sort of in the beginning of the Ukraine conflict, that felt incredibly triggered by that experience and sort of the uncertainty that came with that, not knowing what was going to happen. And I know Morgan's had experiences when we were in COVID lockdown. And again, units basically went into full lockdown in the sense that people really weren't even able to get off the unit, for fresh air, things like that, and sort of veterans' experiences with being re-traumatized with their experiences of being prisoners of war. So just thinking about sort of how these things can overlap and re-traumatize folks later on in life. And then there's this big piece around moral injury, right? And I know somebody in here was talking, there was a comment about sort of, right, the spiritual religious aspects, and maybe Morgan, you can jump in a second, right? But moral injury, right, and the association with it. So moral injury, right, these are events that sort of transgress really deeply held moral beliefs that we have and expectations. And right, they sort of shatter moral and ethical expectations that we might have that can be rooted in religious and spiritual sort of beliefs, or even just group norms, things like that, about fairness, about the value of life, about what's right and wrong. And so they're less likely maybe to be related to more life-threatening things that we might see with like index traumas for PTSD, and more likely to be related to choices that we've made or had to make, or orders that we had to follow. And so sometimes this can come up during life review for veterans, right? It might reopen sort of unresolved emotional and spiritual wounds that they have not spoken about. There's also this whole entire section around self-forgiveness, right? And sort of feeling that they might be worthy of redemption, and sort of the loss of meaning and purpose, and what this means for them as a person as they're sort of thinking back on their life, which I think can be really related to sort of religious and spiritual sort of just engagement. And so Morgan, I'm wondering if maybe you want to talk a little bit about chaplaincy here and sort of how that can come up in terms of moral injury.
Yeah, absolutely. I think we're really lucky to have a really robust chaplaincy program here at Bedford, who many of whom are trained in trauma-informed care. And so they're really aware of this and how this presents, and are able to do this both in a religious and spiritual way, but also in working with agnostic or atheist veterans just towards resolution of spiritual distress. And I think for many, especially of Vietnam veterans, which again is mostly who we're working with at this point, that spiritual distress exists on the same plane as maybe a disconnection with strong religious views. And so I think that disconnect on its own can be quite challenging to know how to resolve. And that's again where chaplaincy often comes in for us, and not always, right? Us as therapists can also help to resolve some of that discomfort as well. But I think I see a lot of veterans preferring to seek out chaplaincy for resolving more of the moral injury pieces here.
Thank you, Morgan. Yeah, and sometimes, right, we think about the cohort effects, right? So for example, right, certainly a Vietnam era war veteran could have moral injury or experience that sort of in terms of things that they've done while in service or when they've seen combat, but also, right, sometimes it can be misunderstood in some ways when we think about how Vietnam era war veterans were received when they returned. And that can also be an experience of moral injury, that perhaps in combat, right, they felt like they had a purpose and a meaning, and they were surrounded by their best friends and really lived through it and survived it. And maybe that's a point of pride for them. And then, right, coming back and the moral injury actually occurring when he felt like he was rejected by the people that he was supposed to be protecting. So again, this sort of sense of like, it can be very nuanced in its presentation as well. So we'll talk a little bit about a phenomenon called later, LATR, right? Later adulthood trauma reengagement. I'll just read this quote because I think it encapsulates it pretty well. And I do see a note in the chat, which I think is duly noted, and I think very important to note. Yeah, it also includes orders not followed and actions not taken. Absolutely. I think moral injury can be all of those things and more that we haven't even touched on. Appreciate that. So yeah, LATR, later adulthood trauma reengagement, right? It's a phenomenon occurring among older veterans who are exposed to stressful war zone events in early adult years, functioned relatively successfully into adulthood, but began to reminisce about combat-related experiences as they confront challenges of aging, right? Like retirement. Later is conceptualized as a meaning-making process, which may lead to growth or increased distress. Right, sort of this pattern that we're seeing of symptom evolution, if you will. And so some challenges of aging, right, they may include changes in health status, confrontation of mortality, and things like that Morgan has spoken to already. But one thing that I really want to touch on in this slide is sort of the mortality piece, right? That at older age, oftentimes folks are being confronted with their own mortality. And this specifically can be triggering for a lot of our folks in terms of PTSD, that seeing death and the dying process later in life may actually bring back thoughts of traumatic losses during combat, military service, or in other spaces in their life, and unresolved loss. So in some ways, right, we think about how sociocultural events can be triggering. This just presentation of your own mortality and sort of dealing with that can also be one of those things as well. I want to shift briefly to talking about substance use disorders. This is the work that I primarily do. Right now, I'm in a residential program for homeless veterans that sort of are managing substance use disorders mainly, or dual diagnosis concerns. And what we know is that the prevalence rate in older veterans is over twice that of older individuals in the general population. We see that with substance use disorders more broadly and alcohol use disorder. I want to talk a little bit about the veteran cohort experiences and how these interface with substance use. I think it's important. I see folks across the sort of lifespan here at the DOM, but I think it's important to talk a little bit about a couple of things. First, that there are higher prevalence rates for alcohol use disorder in Vietnam veterans. We know that, we've seen that in the literature. But also we think about sort of why that might be, or what's sort of going on for folks in this cohort, or in the older adult veteran cohort. Right, we first wanted to talk a little bit about the Vietnam War in general and just access to substances and sort of the receptiveness of using those during that time. We know that drugs were used more heavily than any previous generation of enlisted U.S. troops during this time, right? And so it was pretty commonplace, and it was used not only to boost endurance, right, but it was also used to sort of help relieve anxiety, or sort of stress in terms of the mental health piece as well. So we saw that because of increased access, also just the utility of it. But we were also seeing, right, this counterculture against stateside sort of culture where drug use wasn't necessarily condoned, and also a breakdown in morale. So we think about sort of like the way that substance use was framed for folks who might have been in this conflict and how that can carry through to current use. We also think about spaces where older veterans are congregating, right, where they're sharing sort of camaraderie and experiences and sort of finding that connection, like the VFW or American Legion, sort of spaces where at times there can be a bar, right, and drinks are available and they're accessible and they're not expensive. And so we think about just like the spaces where people congregate to find the camaraderie that's so important to them, but also what's available in those spaces. And we sort of can contrast that, right, with younger cohorts, and perhaps, right, what I hear from a lot of my OEF, OIF veterans is that alcohol was a large part of their experience, right? It's what they did, and it was sort of part of the culture, but we can sort of contrast those a little bit and see that cohort experiences can be really important when thinking about substance use disorders. We also think about, right, just prescription of opioids in the VA hospitals. We think about older veterans who were prescribed opioids in the past for service-connected chronic pain conditions, and sort of the shift nowadays in prescribing opioids and the opioid epidemic and its implications, and sort of thinking about veterans' responses, right, of an expectation of that perpetual sort of prescription and use, and how that can be challenging for folks to wrap their head around, particularly when their pain is quite valid, right? So that's also something that we're seeing as well. I want to consider two comorbid diagnoses here, PTSD and also chronic pain, right? One thing that I hear a lot about folks up here who are experiencing PTSD, right, is that substance use can often be a form of avoidance. What we know about avoidance is that it maintains PTSD. So we want to think about sort of like how these two things interface. And we also want to think about chronic pain. We know that chronic pain affects more than 50% of older veterans. And so this can lead to prescription medication misuse and perhaps an eventual diagnosis as well. So wanting to be mindful of sort of these factors that are really present for folks in this population and how they show up in relation to substance use disorders. There's also, right, the whole conversation around appropriate and controlled pain management. For somebody who's been in recovery for many, many years and they find themselves in a setting where they actually do need to be prescribed something for controlled pain management, and there's this sort of resistance or reluctance to engage in that. So we also have conversations often about, what does this mean for my recovery? You know, what sort of implications does this have about my sobriety, and what does that say about me as a person? And then we think lastly about sort of just the identification piece. What are we looking at? What are we actually seeing? What's happening in the space, right? Sometimes substance use can be hard to identify. Sometimes it can look like natural age-related changes. Think about like confusion or disorientation related to something like maybe alcohol use, and not knowing if that's really alcohol use or dementia, perhaps both. So it can be sort of tricky to tease apart as well. And then I'll end by just talking about SMI, which is something else that I do a lot of work with. But right, the symptom evolution and sort of the experiences of folks with SMI, right, which are sort of any diagnosable mental, emotional, or behavioral disorder that can cause serious functional impairment, that can interfere with life activities, right? So sometimes this looks like schizophrenia or bipolar disorder. But what we're seeing is, right, that rates and severity of medical illnesses are increasing as people age, so particularly heart and lung conditions. We're seeing that psychiatric symptoms can continue to fluctuate as people age with SMI. Also that psychosocial stressors like homelessness, unemployment, poverty, those things are persisting. And we think about Morgan's slide earlier about benefits of that developmental age, and some of these do not align, right? That financial stability piece, not present for folks often who are experiencing SMI. And we also just think about the compounding impact of age-related cognitive decline and dementia. Just a few points about older adults with SMI, right? They're often less physically fit, and sometimes we see that in terms of muscle strength or weaker grip strength. They're also more likely to end up in long-term care at younger ages. They have higher rates of mobility problems, falls, and then also cognitive decline and dementia. Takeaway here I really want you all to get is sort of this idea of institutionalization, particularly early institutionalization, right? For folks who are ending up in long-term care at younger ages. We think about sort of the pieces of life and values that SMI can really impact. And I particularly think of things like agency, freedom, autonomy, self-determination, right? Really grappling with how much say do I have? And we think about institutionalization and how much of people can adopt a patient identity and lose those parts of themselves. And then we compound that, right, with folks at older age who are then also being, right, placed perhaps into long-term care and also facing those similar sorts of experiences and losses. And so we think about how that can really become layered for folks at an earlier age or even just at a more intense sort of level. I think it could be a really significant thing that comes up.
And I'll cap us off here with some psychotherapy considerations, and then we'll breeze through our last few slides so we can leave some time for questions. So just when we're considering doing therapy with older adult veterans, taking first an inventory of their strengths and weaknesses and where can we meet them in the middle, often adapting delivery of material based on sensory or functional deficits. I work with quite a few guys who've had multiple strokes and are limited in their ability to communicate using their words and their mouth, and they use adaptive devices, and that can cause sessions to take quite a long time, right? So doing briefer sessions for folks who maybe have dementia or cognitive impairment and struggle to remain in this space for a longer period of time versus stretching that out for folks who might need a little bit more time. Considering co or multimorbidities that may limit treatment engagement, like I mentioned before, different pulmonary diseases, different challenges to engaging in mindfulness or relaxation exercises. And we may need to spend a little more time on psychoeducation and emotional literacy. Maybe not, right? But this might be the first time someone has ever encountered therapy before. And so it might be beneficial to spend some time, especially in the first few sessions, setting expectations and debunking myths about what therapy looks like, right? I don't know about you, but I'm not a shrink, and I get called that quite a lot. And so I think I often have to say, well, no, you're right. There's no couch in my office. I wish there was, because I could take a nap. But, you know, I think it's challenging a lot of media representations about therapy for older folks as well. So often families and caregivers and other stakeholders involved in older adult care. So it may be a daughter bringing a veteran to a session and doesn't understand why she can't join in your session, right? Why can't she be a part of it? She goes to his primary care appointments with him. Well, that's up to him to decide. Might have to do quite a bit more case management and resource identification than work with younger veterans. I think younger veterans are more aware of how to access things, a simple Google search, or know a guy who knows a guy who knows a guy who can find something for him, right? Older adults are often more isolated, as we've described, maybe a little bit less tech literate, or I'm not sure where to even go on the internet to find that information. And most importantly, when doing therapy, just balancing, advocating for veterans' independence and autonomy with their safety and meeting their individual needs. And so that might mean you find yourself in a place reporting quite often, right? I know that's where I find myself, as fun as that is. And with regard to just treatment engagement, veterans might be resistant to seeking care initially, especially at the VA, right? A lot of stigma around the VA, and frankly, for good reason. And I find that validating that for veterans can go a long way. Older adult veterans, however, are equally and or more likely to complete a course of mental health treatment than younger veterans are, including evidence-based practices, and are more likely to engage in them when offered, but they are less likely to re-engage once they've dropped out. And in my experience with my veterans, I often see them reaching out for boosters or brief follow-up episodes of care to learn how to apply skills we've worked on to new challenges. And this intersectionality piece, I think we had to set aside a little more time for this, and I'll include our notes as well in the PDF. Just consider all the things that may be at play here, right? Opportunities for exploring these with veterans who maybe have never had the venue or the time to do so before, and how all of these factors play together. These are true, yes, for younger veterans as well, but it may mean something different to older adult veterans. I find that often the LGBTQIA identifying veterans have a really valuable time in therapy in a post don't ask, don't tell world, being able to explore gender roles and norms, exploring identities like transgender identities, and receiving LGBTQ affirming care. So if given the space, they will explore. And VA benefits, I'll talk quickly about service connection. Best place to recommend them to is not to you unless you're a VSO officer. So I send most of my folks to their local community VSO. I think there's a misconception out there that people need to be engaged in therapy in order to receive service connection or benefits for a mental health condition. It's not the case, right? The people who make these decisions make them on their own. So maybe you have seen someone for 100 sessions, and your 101st session, he says, well, they didn't give me my money and you said they would if I came here. False, right? I never said that. Your VSO or someone in the community told you that. So it can't help it. I don't ever promise people that it will help or hurt, but regardless, they may take something away from it from engaging with you. And Dipali, I think you were going to comment on pension.
Yeah, so obviously these are all through the Veterans Benefit Administration, the VBA, right? The VA hospitals and medical care is through VHA, so they're separate sort of entities. But I think it's important also to think about the impact of having monetary needs taken care of when thinking about other psychosocial needs for veterans, right? Taking care of basic needs of folks can then actually engage in meaning making and processing and living versus trying to survive. And so the VA pension is one of those things, right? It's a needs-based program. You have to be 65 or older, and you have to meet some criteria around income and military service. And then there's some tack-ons like aid and attendance and housebound that increase that amount, sort of depending on your needs in terms of like, if you're bedridden, right, if you need help, those sorts of things. So just things to think about if you're thinking about decreasing monetary needs for folks or increasing their sort of monetary allowance.
And in terms of venues for support, we got a lot, right? And this is just a list of what we know is available here through the Bedford VA. For those of y'all in other spaces, all of these things might not be available. I will make a note here that if folks are interested in getting veterans connected to kind of long-term care through the VA, there is a service connection requirement for that. But again, that's in certain spaces. So we have acute rehab, physical rehab and skilled nursing here at the VA that requires no service connection prerequisite, right? And our hospice and palliative care unit, you do not have to be service connected to receive hospice and palliative care through the VA, but in order to be admitted to a community living center for long-term care, you do have to be at least 70% service connected. And so exploring this in a little bit further detail with veterans, especially if they're older and on the fence about seeking further benefits, I always encourage them to seek them for this case. God forbid you find yourself in long-term care and don't have the VA as an option. Home-based primary care is excellent for veterans who are unable to attend in-person appointments due to physical limitations, inability to drive, what have you. Get the veterans primary care provider on board and they can submit their referral if it's available in your area. And caregiver support program, awesome for our veterans, caregivers, very supportive. It's also in the name, so maybe you assumed that already. But I've had excellent experiences with them here in helping veterans caregivers get in contact with respite programs and adult day health and all that good stuff as well. So I know we zoomed through this last section, but again, y'all will get our slides so we can take a further look. And I'd like to open us up for about 14 seconds of questions.
All right. Looks like a quiet room. Maybe I think you guys did a wonderful job of discussing many topics in a very short period of time. We really appreciate you taking the time to put this presentation together for our audience and for your care with our military and veteran populations. I would like to thank our audience as well for joining us today, because we wouldn't be able to have these presentations without your interest in our military and veteran populations. So thank you. And I want to remind you of our next presentation, which is May 12th. And that'll be the last in this series. We'll cover military and veteran suicide postvention training. And I want to let you know that we will also be offering a lethal means counseling as a means of suicide prevention in military and veterans. And that will be offered online. That'll be a 4.5-hour training. And this will be the first time we'll be offering it online. And it will be limited participation. So if you do see that come up and you are interested, sign up right away, because it has filled up every time that we have offered it so far in person. So it was very, very nice to host you ladies as our guests. And thank you again so much. Take care, everyone.
Thank you.
Thanks, folks.
Take care.